Welcome, my dear colleagues. I am Dr. Mustafa Mahmoud. Today, in our presentation, we will discuss the management of obesity. Thanks for watching. Don't forget to like and subscribe to my YouTube channel for more video updates. Benefits of weight loss. Moderate weight reduction of 5 to 10% of body weight is associated with reducing the risk of diabetes, hypertension, dyslipidemia, coronary artery disease, sleep apnea, while greater weight reduction of more than 10% is associated with reducing mortality risk. A multidisciplinary team, which includes dietitian, exercise specialist, physician, behavioral therapist, and others as needed, is currently the best model for treating obesity. Treatment options for obesity. Obesity is a chronic disease with increasing prevalence worldwide. The main therapeutic options for obesity includes lifestyle interventions, energy balance manipulation, pharmacotherapy, and finally bariatric surgery. Lifestyle interventions or modifications. The first line of therapy for patients with obesity is the lifestyle intervention, which can achieve up to 10% of body weight loss, aiming to optimizing diet quality, reducing energy intake, and increasing energy expenditure. A good diet quality, like a high proportion of energy intake from fruits, excluding juices, from vegetables, total dairy products, and specific dairy products as yogurt and milk, with low proportion of energy intake from sugar sweetened beverages and fat and high fat foods, reducing the risk of obesity. Energy balance manipulation. In obese patients, weight gain resulted from a positive energy balance through increasing energy intake and decreasing energy expenditure. By reversing the process through decreasing energy intake and increasing energy expenditure, weight loss can be achieved. Energy expenditure. Two types of exercise are described for increased energy expenditure and thus weight loss: aerobic exercise and anaerobic exercise. In the aerobic exercise, oxygen is exhausted in the muscles, but oxygen demands are sufficient to supply oxygen without needs to import oxygen from other sources. The aerobic exercise is the most common type of exercise that proven efficacy for weight loss, which includes involving large group of muscles for long duration with moderate intensity. For example, 150 to 180 minutes per week of running, cycling, or rowing increase fitness and increase weight loss. Anaerobic exercise. It is intense and short duration exercise as weightlifting and sprinting, where oxygen demand is greater than supply, so the body uses glycolysis as a source of energy. It helps to build endurance and muscle strength, but weight loss also through burning more calories can be achieved. So which one is better, aerobic or anaerobic exercise? Both are necessary for achieving weight loss goals. The choice between them should be individualized according to each patient condition and preferences. Energy intake. The following are options for reducing energy intake and achieving an energy deficit in obese patients. 1. Reduced energy diet or RED. 2. Low energy diet or LED. 3. Very low energy diet or VLED. Reduced energy diet. It is a way within patient current eating habits, which aims to produce modest energy deficit of 480 to 960 kilocalorie per day. This can be achieved by encouraging the intake of vegetables, fruits, whole grains, legumes, nuts, seeds, lean meat, eggs, poultry, fish, cheese, yogurt, and minimizing the discretionary foods. Low energy diet. Low energy diet is a diet which high in low fat dairy products, lean meats, as well as fresh vegetables and fruits. Low energy diet aims to reduce total daily energy intake to 1000 up to 1200 kilocalorie. It can be obtained from preparing low-energy meals or commercial formulas and applied through substituting one or two usual meals with one or two low-energy diet meals each day. Very low-energy diet. For individuals who have not responded to reduced energy diet or low energy diet or before bariatric surgery to achieve rapid weight loss, very low energy diet should be advised. Very low energy diet is low in carbohydrate, inducing mild ketosis, which has anorexic effect after 2 to 3 days. The very low energy diet aims to reduce energy intake to less than 800 kilocalorie per day. Individuals take these dietary preparations or formulas that provide all nutritional requirements together, replacing the 3 times daily meals of breakfast, lunch, and dinner. Pharmacologic therapy. Despite implementing comprehensive lifestyle interventions, the failure of achieving weight loss goals of at least 5% of total body weight within 3 to 6 months, pharmacologic therapy is indicated in patients with body mass index greater than 30 kg per square meter or body mass index of 27 up to 29.9 kg per square meter associated with weight-related complication. Orlistat was approved by FDA in 1999. The drug works by inhibiting gastric and pancreatic lipases. It has a local action within the gut to prevent dietary fat absorption. The administration should be during or within 1 hour after a fat-containing meal. The recommended dose is 120 mg orally thrice daily. Together with lifestyle interventions and caloric-controlled diet, orlistat can achieve up to 10% weight reduction within 6 months. Phentermine to pyramide combination was FDA approved in 2012. The combination of both drugs works centrally to create an anorectic effect with appetite suppression and satiety enhancement. Initial dose is 3.75 over 23 mg oral once daily for 14 days. Then 7.5 over 46 milligram for 12 weeks. If 3% of body weight reduction not achieved, then increase the dose to 11.25 over 69 milligram for 14 days, then 15 over 92 milligram. After 12 weeks, if 5% of body weight reduction not achieved, discontinue the drug. The highest dose resulted in average weight loss of 10% within 2 years. Naltrexone-bupropion combination was FDA approved in 2014. The drug works at the hypothalamus and the mesolimbic dopamine circuit to suppress hunger centers. The initial dose is 90 over 8 milligram oral once daily during the first week. Then 180 over 16 milligram during the second week. Then 270 over 24 milligram during the third week. Then 360 over 32 milligram per oral once daily during the fourth week. When coupled with intense diet and lifestyle changes, 10% and even 15% weight loss can be achieved. Liraglutide was FDA approved in 2014. The drug is a glucagon-like peptide-1 analog. It stimulates glucose-dependent release of insulin, inhibits the glucose-dependent release of glucagon, and slows gastric emptying. Administer liraglutide at 0.6 mg subcutaneous once daily for 1 week, then increase by 0.6 mg per day in weekly intervals until a dose of 3 mg per day achieved. 4.8 to 7.2 kg weight loss was achieved, with a greater portion of patients lost up to 5 to 10% of their body weights. Semaglutide was FDA approved in 2021. The drug is a glucagon-like peptide-1 analog. It stimulates glucose-dependent release of insulin, inhibits the glucose-dependent release of glucagon, and slows gastric emptying. Initiate with low dose, gradually escalate at 4 weeks interval from 0.2 mg subcutaneous once weekly to 2.4 subcutaneous once weekly as a maintenance dose. Up to 10 to 15% of body weight was lost with semaglutide. Tirzepatide is FDA approved for treatment of patients with type 2 diabetes in 2022, but the obesity approval is still pending. Tirzepatide is a glucagon-like peptide-1 analog and glucose-dependent insulinotropic polypeptide receptor agonist that leading to significantly improved glycemic control in patients with type 2 diabetes and significant weight reduction. Tirzepatide is used off-label for treating obesity. It is available in various doses of once-weekly subcutaneous injection from 2.5 mg up to 15 mg. The doses can be increased based on hemoglobin A1C and body weight in 4 weeks interval. Up to more than 20% of body weight was lost with the use of tirzepatide. Bariatric surgery. Surgery is indicated when body mass index of greater than or equal to 40, or greater than or equal to 35 kilogram per square meter with severe comorbid condition. The most commonly performed bariatric surgeries are adjustable gastric banding, Row-in-Y gastric bypass, and sleeve gastrectomy. Regardless of the procedure, in the first 6 to 8 weeks, most patients will lose around 10% of their excess weight. In the following 4 to 5 months, it is expected to lose a total of 50% of their excess weight. Over the next 12 months, patients generally will lose an additional 50% of their excess weight. At the end of my presentation, thank you for watching. Please don't forget to like and subscribe to my YouTube channel for more new topics. Till we see you again, goodbye.